Welcome to the Pharmacology series. In our last episode, we explored pharmacogenomics, focusing on how genetic variations influence drug responses. Today, we delve into an equally exciting topic: Introduction to Autonomic Pharmacology. This foundational topic explains how drugs modulate the autonomic nervous system, crucial for maintaining homeostasis. Be sure to check out our companion quiz video with 10 MCQs on this topic. The link is in the description. Let's get started. Autonomic pharmacology explores how drugs influence the autonomic nervous system, ANS, which governs involuntary physiological functions such as heart rate, digestion, and respiratory control. This field is critical for managing disorders like hypertension and asthma and understanding the side effects of medications that affect autonomic pathways. According to the World Health Organization, cardiovascular diseases, often managed through autonomic interventions, account for approximately 17.9 million deaths annually, highlighting its global relevance. In this lecture, we will delve into the ANS structure, its pharmacological targets, and therapeutic applications to equip students with a robust understanding of this essential topic. Let's begin by outlining the learning objectives to set the foundation for our discussion. By the end of this video, you will achieve the following key learning objectives. Understand the anatomical and functional organization of the autonomic nervous system, ANS. Learn about the neurotransmitters involved in autonomic signaling and their pathways. Identify receptor subtypes in the ANS and their pharmacological roles. Understand the pharmacological classes of autonomic drugs and their mechanisms of action. Explore clinical applications of autonomic pharmacology in treating various diseases. Analyze real-world examples and case studies to solidify your understanding. Let's dive into the main content, starting with the structural organization of the autonomic nervous system. Let's look at the structural organization of the autonomic nervous system. The structural organization of the autonomic nervous system, ANS, features a relay of preganglionic and postganglionic neurons, divided into the sympathetic, parasympathetic, and enteric nervous systems, ENS. Preganglionic neurons originate in the central nervous system, CNS, and synapse at autonomic ganglia, where postganglionic neurons project to target organs. Now let's look at sympathetic nervous system. The sympathetic nervous system, SANS, is a critical division of the autonomic nervous system that prepares the body for acute stress, known as the fight or flight response. Originating from thoracolumbar spinal segments T1 to L2, it uses preganglionic neurons that synapse with postganglionic neurons in paravertebral ganglia. Activation triggers physiological responses, including tachycardia, mydriasis, and bronchodilation, ensuring increased oxygen delivery, heightened alertness, and energy mobilization for survival. The sympathetic nervous system relies primarily on catecholamines like norepinephrine, epinephrine, and to a lesser extent dopamine, which act on adrenergic receptors. These neurotransmitters modulate vascular tone, enhancing blood flow to skeletal muscles while reducing perfusion to non-essential organs. A practical example is the use of salbutamol, a beta-2 adrenergic agonist, to treat bronchospasm and asthma by inducing bronchodilation, mimicking the physiological effects of SANS activation on airway smooth muscle. Now let's look at parasympathetic nervous system. The parasympathetic nervous system, PANS, is a division of the autonomic nervous system originating from cranial nerves 3, 7, 9, and 10, as well as sacral spinal segments S2 to S4. It is responsible for regulating the body's rest and digest activities by decreasing heart rate, promoting digestion through enhanced gastrointestinal motility, and increasing exocrine gland secretions such as saliva. These effects are mediated by acetylcholine, which binds to muscarinic receptors on target organs, ensuring precise control over homeostatic functions. Therapeutic interventions often harness PANS mechanisms to address clinical conditions. For example, the muscarinic receptor agonist bethanechol is used to stimulate detrusor muscle contractions in the bladder, improving voiding in patients with non-obstructive urinary retention. This targeted activation of parasympathetic pathways illustrates how pharmacological agents mimic natural neurotransmitter actions to restore normal physiological functions. The third division of autonomic nervous system is the enteric nervous system. The enteric nervous system, ENS, known as the second brain, consists of over 500 million neurons organized into two major plexuses, the myenteric plexus, which controls gastrointestinal motility, and the submucosal plexus, which regulates secretion and blood flow. It functions independently of the central nervous system but communicates via parasympathetic and sympathetic pathways. This intricate system integrates sensory input from mechanoreceptors and chemoreceptors, ensuring precise coordination of digestive processes. Neurotransmitters like acetylcholine and serotonin play a crucial role in the ENS, influencing motility and secretion through excitatory or inhibitory actions. We will look at these neurotransmitters in more detail in the later sections. So for instance, serotonin, 5-HT, activates 5-HT3 receptors on sensory neurons, promoting peristalsis. A practical application of this is the use of metoclopramide, a dopamine antagonist, which enhances gut motility by increasing acetylcholine release at the myenteric plexus, providing symptomatic relief in gastroparesis. Now we want to briefly look at neurotransmitter dynamics in the autonomic nervous system. The autonomic nervous system, ANS, orchestrates involuntary physiological functions through its reliance on neurotransmitters, including acetylcholine, norepinephrine, epinephrine, and to a lesser extent dopamine. Acetylcholine serves as the primary neurotransmitter in parasympathetic pathways and preganglionic sympathetic neurons, while norepinephrine and epinephrine predominantly mediate sympathetic postganglionic responses. Let's look at acetylcholine. Acetylcholine, ACH, plays a pivotal role in autonomic pharmacology as the primary neurotransmitter of the parasympathetic nervous system. Synthesized from choline and acetyl-CoA by choline acetyltransferase, acetylcholine is stored in vesicles within presynaptic neurons. Upon stimulation, acetylcholine is released into the synaptic cleft, binding to nicotinic and muscarinic cholinergic receptors to mediate responses such as smooth muscle contraction, glandular secretion, and heart rate modulation. The activity of acetylcholine is tightly regulated by acetylcholinesterase, an enzyme that rapidly hydrolyzes acetylcholine into acetate and choline, thereby terminating its effect. Pharmacologically, cholinesterase inhibitors, such as donepezil, act by inhibiting this enzyme, prolonging acetylcholine activity at synapses. For example, in Alzheimer's disease, donepezil enhances cholinergic transmission in the brain, potentially improving memory and cognitive function by sustaining higher acetylcholine levels. Norepinephrine, a key neurotransmitter of the sympathetic nervous system, is synthesized from the amino acid tyrosine via enzymatic steps involving tyrosine hydroxylase and dopamine beta hydroxylase. Once synthesized, is stored in synaptic vesicles, ready for release upon action potential-mediated nerve stimulation. Released norepinephrine binds to adrenergic receptors, primarily alpha and beta subtypes, triggering physiological responses such as increased heart rate, vasoconstriction, and bronchodilation. The effects of norepinephrine are terminated primarily through reuptake into presynaptic neurons via norepinephrine transporters, NET, or enzymatic degradation by monoamine oxidase, MAO, within nerve terminals. Drugs like reboxetine act as NET inhibitors, prolonging norepinephrine activity in the synaptic cleft, enhancing sympathetic responses. This mechanism underpins the therapeutic use of such drugs in conditions like hypotension and attention deficit hyperactivity disorder, ADHD. We want to look at epinephrine. Epinephrine, also known as adrenaline, is a potent catecholamine hormone and neurotransmitter essential for the fight or flight response. Synthesized in the adrenal medulla, it originates from tyrosine through enzymatic steps involving dopamine and norepinephrine. Once produced, epinephrine is stored in chromaffin granules and released into the bloodstream during stress, activating adrenergic receptors like alpha-1, beta-1, and beta-2, which regulate cardiovascular, respiratory, and metabolic responses. Its primary actions include increasing heart rate, positive chronotropy, enhancing myocardial contractility, positive inotropy, bronchodilation, and glycogenolysis to supply energy. Epinephrine's effects are terminated by enzymatic degradation via catechol-O-methyltransferase, COMT, and monoamine oxidase, MAO, primarily in the liver and kidneys, with vanillomandelic acid, VMA, as a key urinary metabolite. The pharmacological use of epinephrine harnesses its receptor-specific effects for therapeutic purposes in emergencies. For instance, in anaphylactic shock, epinephrine is administered intramuscularly at a standard dose of 0.3 to 0.5 mg to counteract severe hypotension and bronchoconstriction. Its alpha-1 agonist activity induces vasoconstriction to restore blood pressure, while beta-2 receptor activation facilitates bronchodilation, alleviating airway obstruction. Similarly, epinephrine's beta-1 action improves cardiac output in cardiac arrest when used intravenously. This example illustrates the precision of epinephrine's receptor-based mechanisms in life-threatening conditions. Lastly, we want to look at dopamine. Dopamine is integral to autonomic nervous system regulation, primarily influencing cardiovascular and renal physiology. It acts via dopaminergic receptors, D1 to D5, promoting vasodilation in renal, mesenteric, coronary, and cerebral arteries through D1 receptor activation. This improves renal perfusion, enhances glomerular filtration rate, GFR, and facilitates sodium excretion, natriuresis. At moderate doses, dopamine stimulates beta-1 adrenergic receptors, increasing heart rate and myocardial contractility, thereby boosting cardiac output. Dopamine's effects escalate at higher doses, activating alpha-1 adrenergic receptors to induce vasoconstriction, which elevates systemic vascular resistance and blood pressure. These dose-dependent properties make dopamine valuable in clinical settings, such as managing shock states. For example, in cardiogenic shock, dopamine is administered to improve cardiac output via beta-1 stimulation while preserving renal perfusion through D1 receptor activation at low to moderate doses. Now, we want to take a look at receptors involved in autonomic nervous system. Receptors in the autonomic nervous system are broadly classified into adrenergic, cholinergic, and dopaminergic types, each with distinct subtypes that mediate specific physiological responses. Let's begin by exploring the adrenergic receptor subtypes and their pharmacological implications. Adrenergic receptors are G-protein coupled receptors divided into alpha, alpha symbol, and beta, beta symbol subtypes, each with specific physiological roles. The alpha-1 receptors, located on vascular smooth muscle, mediate vasoconstriction, increasing blood pressure. Conversely, alpha-2 receptors, found presynaptically, inhibit norepinephrine release via negative feedback, modulating sympathetic outflow. Beta receptors, beta-1, beta-2, beta-3, influence cardiac, respiratory, and metabolic processes, exemplifying their diverse pharmacological implications. Beta-1 receptors, predominantly in the heart, increase heart rate and contractility, essential for cardiac output regulation. Beta-2 receptors, mainly in bronchial smooth muscle, promote bronchodilation, crucial in treating asthma and COPD. For example, salbutamol, a selective beta-2 agonist, is used in asthma management, highlighting receptor-specific drug targeting to minimize adverse effects while maximizing therapeutic outcomes. Cholinergic receptors are classified into two main types, nicotinic and muscarinic receptors, both of which respond to acetylcholine, ACH, but differ in distribution and function. Nicotinic receptors are ionotropic and mediate fast synaptic transmission, particularly in neuromuscular junctions and autonomic ganglia. In contrast, muscarinic receptors are G-protein coupled and modulate slower responses, impacting diverse physiological processes like cardiac rhythm, glandular secretion, and smooth muscle contraction. Muscarinic receptors are further subdivided into 5 subtypes, from M1 to M5, each with distinct physiological roles. For example, M2 receptors are predominantly found in the heart, where their activation reduces heart rate and cardiac output via inhibition of adenylate cyclase and decreased CAMP levels. A clinical application of this mechanism is the use of atropine, a muscarinic antagonist, to block M2 receptor effects during bradycardia, effectively increasing heart rate. Nicotinic receptors are divided into NN and NM subtypes, each with distinct physiological roles. NN receptors, located in autonomic ganglia, facilitate signal transmission between preganglionic and postganglionic neurons. NM receptors, found at the neuromuscular junction, mediate muscle contraction via acetylcholine binding. A clinical example is succinylcholine, a depolarizing neuromuscular blocker that acts on NM receptors, inducing transient muscle fasciculations followed by paralysis, commonly used during rapid sequence intubation. Dopaminergic receptors, D1 to D5, are G-protein coupled receptors integral to autonomic nervous system, ANS, regulation, mediating dopamine's diverse physiological effects. D1 receptors, primarily located in renal vascular smooth muscle, stimulate adenylate cyclase, increasing CAMP and inducing vasodilation, enhancing renal perfusion. D2 receptors, found in presynaptic terminals, inhibit adenylate cyclase, reducing neurotransmitter release, and modulating sympathetic tone to maintain homeostasis. Now, we want to briefly look at four major pharmacological classes of drugs that target autonomic nervous system, which are sympathomimetics, sympatholytics, parasympathomimetics, and parasympatholytics. Let's look at sympathomimetics. Sympathomimetics are agents that stimulate adrenergic receptors, mimicking the effects of endogenous catecholamines like epinephrine and norepinephrine. These drugs enhance sympathetic nervous system activity by directly activating adrenergic receptors or indirectly increasing the release of norepinephrine. For example, dobutamine, a beta-1 adrenergic agonist, is used in acute heart failure to increase myocardial contractility and cardiac output. The clinical utility of sympathomimetics depends on their receptor selectivity and the condition being treated. On the other hand, sympatholytics, also known as adrenergic blockers, inhibit adrenergic receptor activity by either reducing neurotransmitter release or directly blocking receptor sites. These agents are pivotal in managing cardiovascular conditions such as hypertension by decreasing sympathetic tone, which lowers heart rate and vascular resistance. A key example is propranolol, a non-selective beta blocker, commonly used for hypertension, angina, and arrhythmias. Its effects are mediated by reducing myocardial contractility and inhibiting beta-adrenergic signals to control systemic blood pressure. Let's look at the third class of drugs, which are parasympathomimetics. Parasympathomimetics are agents that enhance cholinergic neurotransmission by stimulating muscarinic or nicotinic receptors or inhibiting acetylcholinesterase, the enzyme responsible for breaking down acetylcholine. This action increases acetylcholine availability at synapses, amplifying parasympathetic effects such as smooth muscle contraction and glandular secretion. An example is neostigmine, a reversible acetylcholinesterase inhibitor used in the management of myasthenia gravis, a condition marked by muscle weakness due to impaired neuromuscular transmission. Neostigmine improves muscle strength by prolonging acetylcholine activity at neuromuscular junctions. Lastly, we want to look at parasympatholytics. Parasympatholytics, also known as anticholinergics, inhibit the action of acetylcholine on muscarinic receptors, reducing parasympathetic nervous system activity. This results in effects such as bronchodilation, decreased glandular secretions, and reduced gastrointestinal motility. For example, ipratropium bromide is a muscarinic receptor antagonist commonly used in the management of chronic obstructive pulmonary disease, COPD, to relieve bronchospasm. By competitively blocking acetylcholine in the airway smooth muscles, ipratropium improves airflow and alleviates respiratory symptoms. Now that we've explored the autonomic nervous system and its pharmacology, let's take a moment to recap. We've covered the organization and divisions of the autonomic nervous system: sympathetic, parasympathetic, and enteric. Neurotransmitters like acetylcholine and norepinephrine, and their mechanisms in autonomic function. Adrenergic and cholinergic receptors and their roles in physiological responses. Sympathomimetic and sympatholytic drugs, including clinical examples like epinephrine and propranolol. Parasympathomimetic and parasympatholytic agents and their therapeutic uses. Real-world applications of autonomic pharmacology in conditions like asthma and hypertension. Conclusion. Autonomic pharmacology is vital for understanding how drugs interact with the body's involuntary systems. These principles guide the treatment of life-threatening conditions and chronic diseases. In our next video, we'll go in greater detail discussing cholineceptor activating drugs. We'll explore how these agents modulate cholinergic receptors, their uses, and potential side effects. Resources for further learning. For a deeper understanding, refer to Katsung and Trevor Basic in Clinical Pharmacology. Rang and Dale's Pharmacology. Goodman and Gilman's The Pharmacological Basis of Therapeutics. If you found this video helpful, give it a thumbs up and share your thoughts in the comments. Don't forget to subscribe to our channel for more videos in this series. Thank you for watching. We'll see you in the next episode.